Starting in the 1950s in New Zealand, physiotherapist Robin McKenzie developed two crucial ideas in orthopedics. One is repeated movement testing, and secondly is repeated movements used as treatment. Collectively, he called it mechanical diagnosis and therapy because there's a diagnostic test and there's a therapy strategy. And people started calling it the McKenzie method, which is unfortunate to me. But MDT, I think mostly people think about it as treatment, when first it's actually mechanical diagnosis. We are asking the question, does the patient in front of us have a mechanical problem in contrast to a tendon problem or a muscle problem or a structural problem in a bone or a ligament or a meniscus? Mechanical problems, to me, represent the vast majority of orthopedic disorders, but they're missed because MDT, for reasons I will not get into right now, is rarely taught in medical schools or DPT schools or DC schools, and therefore people like me, clinicians like me, need to pursue this understanding of the musculoskeletal system postgraduate. It's a lot of courses after graduation, and you can get further certified or diplomaed in using mechanical diagnosis and therapy if you wish. Nonetheless, the McKenzie method, as people call it, there has a lot of myths surrounding it. And one of the biggest myths, which has a kernel of truth, is that all we do is extend people. And I think people think of that as extending for treatment and not extending for assessment or testing. The truth is that we do extend a lot of people, not only with testing, but as part of treatment. The reason being is a lot of people get their mechanical disorders fixed with extending. And we're not just talking about the spine, we're also talking about the extremities. I extend a lot of people's backs and knees and shoulders and hips and thoracic spines. And when I say I mean typically I'm having the patient do it. It's rare that I have to use any hands-on treatment to get the effects for the treatment portion. So the myth that we extend everyone is not quite right, but it's true that we do extend a lot of people. I think there's two main reasons for this. One is it's how the algorithm is constructed with repeated movement testing. The testing in part 3 of an orthopedic evaluation is dictated by the specific verbal history and the baselines we take in the physical exam. So if all that information, all that data from those two parts corroborate that I think we need to investigate if the patient's disorder is a mechanical joint derangement, then it's my job to determine which test will I choose first. And I choose extension for a lot of people for two reasons. One, it will give us a lot of information because we know the prevalence is that a lot of people will get better with extension. And secondly, I want to find the most fruitful motion first. So it behooves me to try the motion that's most likely to be helpful first. But at the end of the day, testing is not asking the question, does this help? Testing is asking the question, what happens when, right? We're not doing an x-ray to say, does the x-ray help you? We're saying, take an x-ray because we need to know what's going on. And that's what repeated movement testing does. Take, for example, a neck patient. If the patient has symmetrical left and right rotation, left and right side bend, and I apply or I have the patient extend her neck roughly 10 times every couple hours, and the patient now is losing mechanics to the right, losing right rotation, losing right side bend, that informs me as a clinician that I likely need to test a repeated movement to the right. It's not black and white. We may need to look at flexion. Very rarely would I probably go to the left side in that circumstance, but extension has told me this seems mechanical because we can affect the mechanics pretty rapidly over the course of hours or days by doing extension, which is not fruitful. And because of loss of right motion, we probably need to look laterally to the right, but we have the location right. It is a neck problem, and we likely have the diagnosis right that it's mechanical, but now we need to fine tune which direction and how much force and what load we need to use. So extension, like any other test, is going to tell us, yes, we need more of this, but a different load, or we need more of this, but more force, or no, we need movement in the opposite direction, or no, we need movement in a side direction. That's how extension or any motion in repeated movement testing does its job. It tells you where to go next. Ultimately, of course, the goal is to find the fruitful motion, if there is one, as soon as possible. But another kind of bigger picture reason why we use extension so often is because it is so fruitful for most patients. And the reason being, in my estimation, is that it is the movement we do the least, and we do so much flexion. So I don't think it's a surprise that people spend most of their waking hours in spinal flexion, hardly ever go into spinal extension, and therefore fixing their disorder is moving into spinal extension. It's not everyone, but it's a lot of people. And the same thing applies for the extremities. If you spend most of your day in knee flexion or shoulder flexion, it doesn't seem crazy to me to think that restoring or moving into knee extension or shoulder extension on a regular basis can restore a mechanical problem, if there is one, in the extremity joint. There is one caveat. We're not always starting with moving in extension or flexion as the first repeated movement test if there's an obvious deformity of the spine that's relevant. If someone's neck is side bent to one side or their lumbar spine is shifted to one side, that's a great mechanical indication just by observation that we need to start with a lateral movement. But the bigger point is that there are many myths, unfortunately, surrounding MDT. Sometimes I have to dispel them with clinicians and patients, one of them being that we just extend everyone, and we don't. But we do extend a lot of people for testing, and we do find that a lot of people get better with extension or moving their joints kind of backwards, if you will. For most treatments are fruitful into extension, but there's definitely a significant minority of people who need either movement to the side, such as rotation or side bend, or extension with a lateral component of movement, or flexion, protrusion in the spine, which is going forward.